Hi, today I'm here with Vito Evola. Hi, Vito.
Hi.
Vito Evola is researcher within the Institute of Philosophy of the Nova University of Lisbon. As a researcher within the Metacare project, he is interested in investigating how theories of conceptual metaphor and gesture studies might be applied to doctor-patient interactions and discourse in the context of diabetes. Today, Vito is going to give a talk. The title of his talk is What's in the Language of Informed and Shared Decision Making in Healthcare? Insights from Cognitive Linguistics.
Okay, well, first of all, thank you, Maria Grazia, for your invitation and for organizing this conference. It's already difficult to organize a normal conference, and I know a lot of time and energy went into organizing this, so thank you. The keynote speakers did a wonderful job of explaining shared decision-making and the need to rethink what that exactly means. I hope today I'll be able to contribute to that discussion by providing some insights from cognitive linguistics about how people communicate. Next slide. So it seems common sense that people exchange bits of information back and forth, like questions and answers, for example, like little building blocks to reach a decision or a common understanding. However, in truth, the speaker and addressees try to do something more at the same time. They establish the mutual belief that the addressees have understood what is uttered to establish what the speaker meant as common ground. The process of contributing to a conversation consists of both specifying some content and grounding it. In healthcare settings, there's a deeper challenge in communication. The patient might say they understand what the doctor is saying, even if they really don't. The doctor might have pre-established biases which motivate their decisions and what they communicate. But because of the nature of the healthcare context, it's evident that most of the responsibilities of how decisions are made, or at least the results of these decisions, lie mainly on the doctor more than on the patient. In fact, any decisions made were ultimately chosen and offered by the doctor to the patient. Next. And so, as the keynotes have said in other words, the communicative contributions in the decision-making process are interactionally developed, but they are not completely shared. And there is an epistemological and ethical asymmetry weighing in on the doctor. So healthcare providers face a number of epistemological challenges when communicating with patients because they don't have a proper comprehension of the technical language or of the ideas that are being presented. There are also some ethical challenges, like the struggle of being objective and not bringing with them any biases. The aim of my talk today is to look at some of these challenges from the healthcare provider side from a cognitive linguistic perspective, specifically focusing on the conceptual, communicative, and decision-making bearings that metaphors, metonymies, and frames have when talking with patients. I will try to shed some light on some hidden features of language used in healthcare contexts, features which can easily go unnoticed, but which can determine how decisions are made. One of the challenges healthcare providers have is not introducing their own biases. Biases can be manifested in language, as I'll show in a moment, and they create other biases, influencing one's own decision, even without us even being totally aware of them. And when communicating with patients, these biases that are hidden in language and metaphors, they can influence patients' understanding and ultimately even their behavior, having a highly persuasive or even suggestive quality. Next. So my first example comes from the context of mental health care. These doctors and practitioners are trained using the DSM, a manual which provides explicit, official, and precise definitions of various psychological disorders for them to use when diagnosing and treating their clients and patients. The language used in this manual was designed to be linguistically neutral and diagnostically descriptive and literal. Next. But the language used, in fact, has a lot of metaphorical language. So thoughts are metaphorical objects which move, and they can move together like a train or like a stream. So they talk about derailment and flow of thoughts. These metaphorical moving objects can sneak up on you like an enemy, and you can have panic attacks. And the patient is reasoned as if they're driving the car of their thoughts, and they go out of control. And there are many more metaphors like this. Next. Ultimately, what happens is the clinician who is trained using these metaphors found in the manuals adopts them to scope the diagnosis of a patient and ends up suggesting the patient an interpretation based on these metaphors. Consequentially, the patient understands the metaphor conceptualization relative to their symptoms and adapts these metaphors, thus interactionally developing the usage of the same language. Next. So here's an extract from a psychiatric transcript. Notice how the psychiatrist starts suggesting the language to be used, which is picked up by the patient. Mr. Neal, do you often have embarrassing thoughts that pop into your mind against your will again and again? No, not really. Or thoughts that torture you, that you can't resist, that you spend a lot of time on? How do you know? I'm asking you because some of my patients are bothered by intrusive thoughts. Well, I'm embarrassed to tell you, even though the thoughts are not embarrassing, just that I have them, they drive me crazy. Tell me about them. Well, I had to quit my job last month because I was so slow. Whenever I picked up a tool, a thought came up. Does God want me to pick up the tool? Does he want me to pick it up now? Do I do the right thing? Should I do something else instead? I know it's silly, but I have no control over these thoughts. Next slide. So as you see, these metaphors of thoughts being enemies that sneak up on you and torture you, or thoughts driving the patient as if he's a car and he has no control over them, and others, they're picked up by the patient who uses them in his own line of reasoning, perhaps highlighting these rather than other symptoms. Next. So what does this mean? The language of psychopathology is anything but neutral and literal. The metaphors the psychiatrist uses also have the power to create symptoms and pathologies. Now, all language we use is infused with metaphors, but the choice of metaphors we use does frame how we reason about things. A couple of weeks ago, Caring Discourse had an episode on #ReframeCovid and how certain metaphors attract certain lines of reasoning. At the same time, it's also possible to provide alternative frames, alternative metaphors, which may actually be therapeutic as opposed to pathogenic, because the way we talk about things conditions the way we think about them too. Next. In a case study on metaphors being used between a client with a form of depression and his therapist, one pathogenic metaphor we identified was therapy is war. The therapist was trained to identify metaphors and to propose a reframing through a therapeutic metaphor. In this case, life is a struggle. Next. Metaphors are especially used when trying to reason and communicate about something abstract and hard to describe. And as you see, there was greater metaphorical usage overall in the beginning of the therapy sessions. Towards the end of the therapy, there was less need to talk about the illness abstractly using metaphors. Next. But what's more interesting is that progressively the usage of pathogenic metaphors decreased thanks to the reframing and shifting the way of thinking and talking about the problem. Next. We know that talk therapy for patients with depression like this one over time have about the same success rate as patients given medication. And what's more interesting is that people who have gone through talk therapy have less risk of relapsing. Next. So there seems to be a significant effect when people reframe their concepts using different language. In my last example wants to look at metonymic framings. Metonymy is sort of a linguistic shorthand, like when we say, let's do a head count to mean, let's count how many people, or I like Mozart to mean I like the music produced by Mozart. Next. The data I'm presenting today is a work in progress, and it's of a series of Italian doctor couples consultations in the context of art or artificial reproductive technologies. Here, a doctor is talking to the female patient and says, I don't want to stimulate you too much because I think it's better to plan for a situation of having a few good quality eggs than to force the situation. The first metonymy is stimulate you. What the doctor is talking about is ovarian stimulation, where the ovarian follicles get hyperstimulated. Here, the patient, you, stands for a body of her, part of her body, the ovarian follicles. So this type of metonymy is found in everyday language. For example, if I should say, Paul punched Tom, where I'm only referring to part of Tom, say his face. I'm not referring to Tom entirely. But there's a second metonymy, which is what I want to focus on, good quality eggs. And this type of metonymy is frequent in art discourse. Next. First of all, let me say that the usage of this type of evaluative language, like good, in relation to a patient's eggs or sperm, has a negative effect on some patients. The reason why is through metonymization, there's a transfer of the evaluation from the part to the whole, that is, from the part of the body to the entire person. But also, this negative effect is motivated by another metonymy. The producer stands for the product. Eggs and sperm in the end serve for reproduction to create copies of the parents as they contain the DNA, the essence of the persons. So not having good eggs or good sperm makes some patients feel defective or flawed in their person, not just in the part, but as a whole. And if their sperm or eggs are not good, that evaluation is transferred back to the producer, the patient. Let me read you an example from our data, and notice how this type of metonymy is used twice by the patient and the doctor, and how linguistically body part and person get conflated. So the doctor says, 37 of age, we're still within the limits. Your FSH is slightly higher than what it should be, but your AMH is good at 3.4. Your ovarian reserve is overall still good. I'm not a total piece of scrap yet. No, you're not a total piece of scrap yet. And of course, we have to see how you respond to therapy. For example, if we stimulate you, will your ovary respond? Next. In reality, the usage of good and not good is appropriate when taking into account what good is in reference to, and that is the process of fertilization. When we contextualize good in relation to the process, rather than leaving it to be indexicalized to the patient themselves, we start seeing that it becomes completely possible to look for alternatives to using good, such as appropriate, conducive, viable, and so on. Next. So just to summarize a bit, metaphors and frames are hidden in technical language, motivating ways of thinking and behaving of professionals and consequently of patients. Professionals aware of metaphors used by patients are able to provide more responsible care by identifying potentially more helpful alternatives to reframe their way of reasoning about the situation. And seemingly innocent language may have epistemological and psychological effects, which can be avoided via disintegration. Next. So, in closing, whatever shared decision making, the professionals have an ulterior ethical responsibility to ensure that the interactionally developed communication is patient centered. That is, establishing the mutual belief that the patient has understood what is understood, and to establish what the professional meant as common ground. Hence, we need to develop greater cognitive linguistic tools and strategies for better informed and collaborative decision making in healthcare. Thank you.